Hello and welcome to today's webinar. Thank you very much for taking time out and being here today. My name is Ayong. I am the Marketing and Educational Seminar Coordinator here at NeoBiotech. And this is me right here. And hello and welcome again. So today's agenda is very simple. It's to introduce our topic and the presenter. And I will go over some communication tools. And at the end, I will make an announcement in regard to upcoming webinar and also watch previous webinars. And lastly, how to receive your CE credit. So please don't leave and stay until the end. So today's topic is the hard and soft tissue considerations in implant dentistry with Dr. Jason Kim. And we are also strongly recommended to use chat box. It's right here to communicate with me, ask technical issues, and other than the topic. And we will have a Q&A session at the end, so please submit your questions through this Q&A box. And one thing that I want to mention is that Dr. Kim may not answer all of your questions since we have a short period of time. And let's have Dr. Kim to start the webinar. Good morning, Dr. Kim. How are you doing?
Good morning. Very well, thank you. I hope you and everybody is doing well in the midst of all this craziness. So thank you for having me.
No problem. Thank you. Thank you for your time.
Okay. So do you see my my screen?
Yes, I do.
Okay, great. So should I begin?
Go ahead, doctor.
Okay, very good. Well, yes, I'd like to thank you again, Aya, for this warm invitation, and especially in these times, you know, with the way this pandemic is affecting everybody's lives. I hope everybody watching and everybody around is doing well, safe, and hopefully that we will overcome this very soon. I know we're all anxious to get back to work, get back to socializing, and I just wish everybody the best. So with that, I'd like to just begin my presentation today. It's going to be an hour webinar. I am from New York City, from those that are abroad. I did my training at NYU, and I stayed on as faculty there for a number of years. And what you're seeing here is actually the implant program, the 2-year implant fellowship program, where we have participants come to learn implant dentistry and everything from treatment planning to the restorative to the surgical phases. And, you know, we train lots of dentists that are coming out of dental school. So these are practicing clinicians who want to advance their skills and their careers with implant dentistry. So it's been a great experience. And I do want to extend my gratitude to NYU. So I am in private practice as well. I have an office in Queens. I had an office in Long Island as well with a partner. And until a few years back, I decided to sell that second office, Long Island Dental Group. And I went back to school to pursue my certificate in periodontics. And I'll be completing that within days, I hope. So I'm very excited about that. And to say the least, that it's definitely been a great experience. I think that is going to benefit me, not just only as a clinician, but for my patients as well. So I want to thank Rutgers, and I just a quick shout out for them giving me the opportunity to even pursue this next chapter of my life. So thank you. That's my email. I am on Facebook. You know, some of the cases that I'm going to just present. You can, reach out to me. We can always collaborate. Questions, comments. I always welcome comments. Everybody does certain procedures different ways, and it's always about sharing, collaborating, and learning from one another. So hopefully what I can share today will give you a little bit of eye-opening experience to be able to see if you can implement some of the procedures that have worked for me as well. So, and with that, some of the things we want to discuss with you today is going to be understanding some principles for both hard and soft tissue augmentation. Now, to try and go over everything in an hour is going to be difficult and challenging, but just want to give you an overview, kind of reviewing some of the things that I look for when I'm involved with implant dentistry. We'll learn some of the different grafting solutions in both hard tissue and soft tissue that'll help us give us more predictability, and understanding some of the clinical indications and maybe some of the materials that I use for certain procedures. And so with that, we have to understand that there has to be a rationale for grafting. When do we graft? the timing of grafting, some of the materials that we use, and how long do we have to wait after we use some of these materials, right? So hopefully we'll touch upon that as we go through this presentation. And so when we look at grafting, and we have to think about soft tissue and hard tissue, we can't just look at one component without looking at the other component. So if there's a deficiency in one area of the mouth, it's usually not just localized to either just a hard or soft tissue. If anything, it's probably a combination of both, and we need to address both situations to give us the results that we're looking for. Sometimes we can do both hard and tissue at the same time, sometimes we can't. And essentially, when we're looking at hard tissue, it's really the underlying bony foundation that we want to implement, right? We're trying to improve the bony conditions. We're trying to either build a ridge, build up horizontal, build up vertical augmentation. And then when we look at soft tissue, it's really the biotype that we want to consider. So and today, from the 2017 AP consensus, now they're talking about it's not really biotype, but we're looking at phenotype, not just the soft tissue, but the amount of buccal bone that's underneath as well. And looking at that whole picture, whole scenario. And ultimately, especially in the anterior aesthetic zone, about the patient's smile, and ultimately resulting in how are we going to achieve the best possible aesthetics for this patient? If we have the hard tissue, do we have the soft tissue? And can we predictably be able to improve upon or regenerate, what we're looking to achieve? And so again, we have to look at ourselves as being a clinician that can be able to incorporate and involve both the hard tissue and soft tissue, so that today, 2020, we can incorporate the best possible aesthetic results as we can. And I'm sure most of you have heard this quote from Maurice Lama: "The bone sets the tone, but the tissue is the issue," right? So then how do you deal with each component, right? And hopefully understanding some of the parameters that will lead us to giving us success. And from this success, I think it's only from our failures that we learn how to really become better clinicians, how to become more successful. And sometimes there is risks involved. And if we're not a clinician that's looking to try to achieve the best possible results for our patients, then we need to try and find ways that's going to help us to implement those techniques that will give us the best results. And so when we look at success, again, as I mentioned, it has to be both dependent upon both the hard tissue and soft tissue components. And only when both components are in harmony will we get the final aesthetics. And as we look at the aesthetics, we have to understand that it's all related to the implant position, the amount of facial bone that's present, right? That allows us to have the specific form and shape of the restoration, and understanding about the soft tissue that's going to be encompassing around that implant area. And ultimately, what it really comes down to is prosthetically driven implant dentistry, meaning crown down implant dentistry. So we have to understand what's the final result, what the final goal is going to be, and then come up with a plan, an ideal treatment plan that will give us the best possible results. But unless we have that vision in mind, understand what the final prosthesis is going to look like, we can't devise a treatment plan sequentially. So it really has to start with the prosthetics. And looking at this case here, this was from another colleague of mine, but you obviously see some problems that are going on with this case. And we know from Evan's article in COIR back in 2008, he says that gingival recession really will increase in patients with thin biotypes. And I think with our experience, we see that quite often. And especially maybe from clinicians who may not be as experienced in implant dentistry, if they don't really pay particular attention to the soft tissue, to the phenotype, biotype, you can be sure that you're going to see some of these complications. And then it's going to be, how do we manage and how do we deal with these complications, right? So gingival recession is really one of the most common problems that we encounter with anterior implant dentistry. And so understanding the foundation, understanding how do we manage those complications will make us the better clinician, will give us the better results for long-term stability for our patients. Again, here's another example, just showing you the thin biotype. And we can expect to see these types of results in cases where we have thin tissue. Maybe the bone's not there, right? Maybe we didn't have enough bone, right? But what's the ultimate underlying dilemma with this problem? Maybe it's one or the other or both, right? So the best solution is really, how do we avoid these types of complications? How do we minimize these types of complications? Looking at this case here as well, you can see the radiolucency that's coming through the soft tissue, right? You can see the shadowing effect from the titanium abutment or the implant itself. But understanding with thinner biotypes, we're more prone to having recession over the long term. And if we're looking for long-term stability, long-term success, we have to understand the biological principles, not just for the hard tissue, but for soft tissue as well. Because ultimately, this is what we want to see, right? Looking at this case here, this is a central incisor tooth number 8. The soft tissue profile, the biotype, the phenotype around that implant is very healthy. And that's what we want for all of our cases. And so we have to understand when we have implant dentistry in our forefront, this is the type of tissue that we're looking to have, right? This is what we want to see when we expose our implants, when we do our recovery. We want to make sure that we have the soft tissue support foundation that's going to give us that longevity for our implants. And ultimately, with this solid and stable soft tissue environment, will give us a long-term, very stable prosthetic result. And so when we look at the goals of soft tissue, it's really to really have a support, a seal around that tooth or implant if we're working with implant dentistry. That way it will give us that bony support and ultimately that soft tissue aesthetic support that we're looking for our aesthetic cases. And so this is ultimately the type of results that we want to achieve for all of our patients, especially in the anterior aesthetic zone. And so when we look at the periodontal functional anatomy, we have to kind of evaluate, the differences between tooth and implant a little bit, looking at the role of keratinized tissue. Is there a clear distinction between having a thin and thick biotype? And you've seen in the previous examples that there is a distinction. There is a necessity to have a thicker biotype. And so we've come a long way since our studies and since understanding, going back to George Gargiulo's work with biologic width, there's a clear distinction between the different fibers that circumferentiate around an implant versus a tooth. And it's obvious to see that what can happen when you look at the picture on the right, when we can probe around an implant, where if we don't have a stable soft tissue environment, we can expect to see that recession. Whereas with teeth, we have that collagenous fibers circling around the tooth, where we have that dense fibers that's going to be able to support any type of any irregularities around the tooth. So we want to have a stable environment, which leads us to understanding the role of keratinized tissue to be able to withstand the stresses of normal chewing, normal mastication, brushing, trauma. And that's why we need to have that keratinized tissue, right? It'll help prevent wound opening, helps resist muscle pull. And so the question was asked before, do we really need to have keratinized gingiva? And it's been debated in the years previous. Some clinicians have said yes, some clinicians said no. Some of the studies have shown that, there is a need for keratinized tissue. Back in the 70s from Lang and Lowe studies, Maynard and Wilson studies. But then there's also clinicians on the other end of the spectrum who say that there really isn't a need for keratinized tissue, right? Maybe only a millimeter of keratinized tissue is enough. Wenstrom was a big advocate of not needing keratinized tissue. But I think we've seen from the studies and experience today that keratinized tissue definitely plays a vital role in the success of our cases. So we need to understand the soft tissue role and the hard tissue role, and really having a connection between the two to be able to understand how do we achieve success, how do we maintain stability, and how do we have long-term success for those aesthetic cases. So when do we perform soft tissue augmentation? There are different times throughout the treatment that we can perform these different procedures, either before implant placement. We can even do it during implant placement, sometimes at second stage uncovery. Sometimes we may have to perform procedures after restorations have been restored, and even during the maintenance. Sometimes we'll see cases where we think we have enough keratinized tissue, where we think we have a wide band of support around the implants, but 5 years, 10 years down the road, we see that there's been some relapse, there's been some resorption, some dieback, right? Some relapse of the tissue that we once thought was thick enough. But now what do we do, and how do we manage those types of cases? And I can be the first to tell you, in my practice where I have been seeing implant patients for a number of years, I'm actually doing a lot more soft tissue augmentation procedures today than I was, say, 3-5 years ago. Just paying more attention to the need for having stable soft tissue support. So I'm doing a lot more free gingival grafts, connective tissue grafts around implants that have already been restored, because I'm seeing the recession effects from having a thinner biotype. So we definitely do need, I think, to understand the basis and the foundation necessary to be able to have that successful case long-term, aesthetic-wise, for our patients. So if I had a choice today, I would much rather try to address those soft tissue needs either before implant placement or even during implant placement. But even some cases where I can do it on uncovery stage, I'm always willing to do that second stage uncovery stage in conjunction with a soft tissue uncovering. It's actually much more difficult and more timing, takes more time, takes more skills to do it after restorations have been completed, and even during the maintenance phase. One thing is patient management. They'll come to you and ask you, it's like, why do we have to do this now? Why didn't you do this before? You know, why did the soft tissue shrink, or why did we get relapse? You know, why didn't we address this from the beginning? So those are all issues that we want to try and avoid. And I would say the best scenario would be at the time of either implant placement or even at the time of uncovering. So we have that option. And so understanding, there's a flowchart that came out in 2017, and this was actually a very a good flowchart that I kind of referenced. If you look at this chart here, there's two columns here, one on the left and one on the right, that says adequate keratinized tissue versus inadequate keratinized tissue. And it goes suffice to say is that also it evaluates the amount of bone present. And so if there are cases where bone is present, then maybe you can go ahead and place your implant with enough keratinized tissue, as you see all the way on the far right of the far left of the screen. In cases where inadequate tissue is present, but you have insufficient bone, then you may need to do maybe bone augmentation procedure in conjunction with soft tissue augmentation, or you may need to do the bone augmentation first, go back and do the soft tissue augmentation later, or even maybe have to do the soft tissue augmentation first before doing any other bone augmentation procedures. So you see that little flowchart all the way to the right where it says insufficient bone. You have about 8 different scenarios to be able to address the lack of keratinized tissue and the lack of bone, either doing one component at a time or in conjunction with each other, or doing it at a stage later approach. So this flowchart actually is a good reference to use in terms of how do I sequence my case? How do I sequence my case depending upon the soft tissue foundation and also depending upon the hard tissue foundation? So it's just a good reference to follow in case, to give you some predictability and to give you some guidance for that. So when we look at principles of soft tissue grafting, we have to understand basic surgical principles, meaning the recipient site must have vascularity, right? So that means we have to have a good blood supply. That's what we want to see for our surgical cases, good vascularity. Graft immobilization, and whether we're doing soft tissue or hard tissue grafting, we want to make sure we have graft immobilization. Everything's got to be stable. We can't have any movement with whatever areas we're grafting. You want to have good hemostasis. You want to make sure that the donor site is large enough, right, to be able to account for immobilization and to be able to account for any possible relapse in the future. But also you want to take advantage of the peripheral collateral circulation to be able to give it the blood supply. And you want to make sure you have adequate thickness of the graft material, which we'll discuss upon in a little bit. So how do we gain keratinized tissue? There's different ways of gaining keratinized tissue. We can do an apically positioned flap. We can do free gingival grafts to be able to increase the amount of keratinized tissue. We can do connective tissue graft that will allow us to have increase in keratinized tissue. But one of the simplest ways with implant surgeries is if we can apically position our flaps, that will be one of the more simpler ways of being able to predictably give us the keratinized tissue that we're looking for, provided that we have a decent band of keratinized tissue on the crest. And so just looking at the schematics here, if you see the picture on the top left corner where it says lingualized incision, that means we want to make our incision more to the lingual or palatal where we have more keratinized tissue present. In cases where maybe the mucosa may be a little higher up, you want to see where that delineation is and be able to bring your keratinized tissue over with your incision design. So that's why when we're doing our incision designs, in many cases, whether I'm doing it as a 1-stage or 2-stage approach, I will traditionally try to make my incision more towards the lingual or palatal so I can ensure that I have a little bit more keratinized tissue when I'm doing the procedure. And whether I can do this as a 1-stage or 2-stage, hoping to do this as a 2-stage, I'll be confident that I have the amount of keratinized tissue that's going to support that implant for final restoration. And so here's just another case that I want to describe for you. And if you look at this example here, you can see the delineation between the keratinized tissue and the mucosa. So this is all mucosa here, right? So how would you make your incision? And obviously you can tell from my incision design, I made my incision more towards the lingual, more towards the palatal, so I can bring over that keratinized tissue to the facial. And so by doing this apically positioned flap, it minimizes the need to do any future surgical intervention in case I may have a lack of any keratinized tissue. So I can go ahead and make my incision more to the palatal, bring over the keratinized tissue, perform my implant surgery, and then suture so that I can be ensured that I have a good, thick, wide band of keratinized tissue that's going to support the facial aspect of where the implant's going to be. So here's my osteotomy preparations, implant fixtures placed, healing collars, and here's, you can see how I was able to bring over the flap to the facial, and because I had good primary stability, I wanted to place healing collars to treat this as a one-stage approach. And now this Palachi technique is used so that I can try and maximize the amount of soft tissue to try and see if I can gain some papilla between the implants. And so what this technique is doing is I'm taking a band of tissue to be able to try to improve the chances of regenerating some papilla between implants or even between implants and teeth. And so what we'll do is from the schematic, as you can see, I lay my incision more to the lingual, and wherever I have the widest band of keratinized tissue, either from the buccal flap or from the palatal, I can incise a small wedge of tissue, not dissecting it, keeping it connected at the base, and I'm going to swing over that tissue interproximally or interimplants. As you can see from the picture on the top right, I'm going to swing over that band of tissue so that it will mimic the looks of what a papilla is going to form to be placed within the two implants that you see in the pictures. So I can swing that over, and then we can stabilize that with some sutures. So here's an example where I made an incision more towards the lingual. I brought over the buccal flap, exposed my implants. So this case was done as a two-stage approach, exposing the implants underneath. Placed healing collars for uncovering, and you can see the wide band of keratinized tissue that I'm able to bring over to the facial. And then I'm going to go ahead and initiate a couple Palachi technique implant flaps. So I'm going to make an incision across here, keeping it connected at the base, and we're going to swing this band of tissue in between the two implants. And as we swing that in, that's going to help possibly generate a little bit of papilla formation, so that way for the prosthetic results, it'll have a much more long-term stability for the prosthesis in terms of maintenance and hygiene for the patient. And then we can secure those little flaps with some figure-8 interrupted sutures. And then after a few weeks, this is a type of healing that we want to be able to see between our implants, hoping that we can have some papilla shaping between those two implants. But look at the healthy keratinized tissue that we're able to achieve. And we can do this predictably by understanding the biology, by understanding the anatomy. Where do we have the mucosa? Where do we have the keratinized tissue? Understanding by just by making our incision more towards either the palatal or lingual and being able to bring that tissue over to the facial, that will ensure that we have a guaranteed band of connective tissue that's going to surround and support those implants. And look at the sulcus around those implants. Nice, healthy pink gingival around those sulcus. And we can be assured that long-term stability, we're going to have good success with these types of cases. So we want to make sure that we have that support. Now at this stage, now we can go ahead and proceed with our final impressions and then take that to completions. So we need to pay attention to those little details. And especially with the soft tissues, you know, those details, those minor details, it goes a long way in terms of long-term success, long-term stability. Now, this was a case that was performed by another colleague, another resident of ours, after the fact, after the implants were placed and during the restorative phase. Thin band of keratinized tissue, but to ensure that we have better stability, we want to do a free gingival graft so that we can have better soft tissue, keratinized tissue support for the longevity of those prostheses. So here we're just doing a traditional free gingival graft, securing that around the implants. And now we know that we'll have a nice wide band of keratinized tissue that's going to give us support for our implants and prosthesis long-term. So here's a case, implant site number 28. And this was the case I showed you earlier before we began the presentation. Now looking at this, now there's a combination defect going on in terms of not just hard tissue, but hard and soft tissue, right? So when you look at this type of case, now how are you going to plan this case? How are we going to approach this type of a defect? Now, it's pretty obvious that we have a hard tissue defect. And it's pretty obvious that because of the hard tissue defect, the soft tissue follows the contours of that hard tissue defect. And because of the lack of bone, the soft tissue, you can see the deficiency and depression that's present in this case. And so we had treatment plans in this case to go ahead and place our implant, doing this together with the GBR. Here's our CBCT. We had some width available, considering that from the clinical view, it didn't seem apparent that we had enough volume of bone. But from our CBCT analysis, we can see that it was at the crest that we had a narrow crest of bone. But as we went down, as it went down more apically, we were able to have a wider, broader width of alveolar bone present. And as such, we were able to plan this case to place a fixture, a short fixture, but in the premolar site. And as you recall from the clinical picture, we had the space enough to be able to warrant a premolar size fixture to support a premolar size crown. So we had about 6 millimeters width, reducing the crustal portion of that lip there. So we're going to flatten that bone a little bit, and then also understanding the limitations of where the inferior alveolar canal is. So we're going to plan to place an 8 millimeter length fixture, and then together in conjunction with GBR, but also see if we can address the soft tissue concerns as well. So you can see we have our implant fixture with our guide pin in place. You can see the incision design that allows us to have a more predictable positioning of our keratinized tissue if we have a wide band of keratinized tissue. Making some, in this case, I think I did pupillary sparing incisions so I can minimize possible resorption of the interproximal tissue against the adjacent teeth. So we're doing this as a full thickness flap. You can see now, you can see the osteotomy preparation. Now you can see the little concavity there that's present over here. So, but we did have a wide band, as you remember, as you recall from seeing the CBCT. It was at the crest that we had a little bit more narrow band, but as it went down more apically, we were able to have a wider band of bone present. So here's the implant fixture placed. Now we're going to go ahead and provide decortication so that we can do a GBR simultaneous at the time of implant placement. GBR procedure carried out. In this case, I used PRF membranes. We're not going to really go into PRF technology here, but I use PRF, platelet-rich fiber membranes. But looking at the soft tissue profile here, you can see the patient actually had a decent band of keratinized tissue, right? So by making my incision to the lingual and understanding that for this case, we're going to treat this as a two-stage approach, but looking at where the mucogingival junction and where the keratinized tissue is, we have a decent band of keratinized tissue present. So for this case, we did some GBR implant placement. Maybe we didn't have to do some soft tissue augmentation. And then here's my implant position. You can see the bone graft that was placed over and about the implant. And then here's my implant. So with proper planning, we can ensure that we have our implant fixture placed in the correct position, placed within the alveolar housing that's in a correct restorative position. So we took all this information before we did our surgical procedure, so that we understand that where we want our implant to be, provided that we have the alveolar hard tissue support. And because we have that hard tissue support, we were able to undermine and be able to have the regeneration procedure. And in this case, I didn't need to do a soft tissue augmentation procedure because of the amount of tissue that was already present. Now, this patient was referred to me from another office, so he went back after uncovering, and he was having the restoration completed. But we saw him for a follow-up, and I forgot to put the final picture here. I apologize, but we didn't have to do a separate soft tissue augmentation. And so you understood when I went in for uncovery, I made my incision more toward the lingual so I could bring over that keratinized tissue. And so understanding what are the parameters to have successful grafting procedures. And whether it's soft tissue or hard tissue, we need to have that blood supply, right? We need to have that space maintenance. We need to understand that without being able to have a stable environment, we're not going to get good regeneration, whether it's hard tissue or soft tissue. So graft immobilization, good blood supply, good space maintenance. And then I put an asterisk here in terms of infection-free environment. And also in larger GBR cases, we want to make sure that we have primary closure, and not so much in socket preservation. I'm going to show you as we segue into hard tissue augmentation procedures now. And together, giving it time, will ensure that we have more predictable regeneration, whether it's hard tissue or soft tissue. So we have to understand that we need the signals, we need the cells, and we need the matrix that's going to allow us with the correct environment to give us that regeneration of bone. So we need those cells, the signals, and it all stems from that blood clot, having good blood supply. And so I want to show you this simple socket and understanding the treatment sequencing in terms of what the final goal is going to be and how we're going to come up with a treatment modality, treatment plan that's going to give us both hard tissue and soft tissue predictability. So this is a case that any one of us will be seeing in our patients, in our offices on any given day. Patient comes in with an abscessed tooth, with a failing root canal treated tooth, unrestorable. Treatment options presented to the patient to possibly maybe retreat the tooth or extract the tooth, considering the pros and cons for each option. So we opted to extract this tooth. You can see the recurrent decay going through the crown of this tooth number 30. So we opted to plan to extract this tooth, socket graft, and then place implant at a future time. So this was done in June. We sectioned the tooth for atraumatic extraction so that we can actually treat 2 smaller sockets versus 1 large socket. So we try to maintain that interceptor bone as much as possible. And I try to do that with all of my molar teeth, whether it's a mandibular molar or a maxillary molar teeth. We try to section the tooth so that we can try to preserve as much alveolar bone, interceptor bone that may be remaining within the socket. Because by essence, by retaining and trying to minimize any trauma to the alveolar housing, that actually will allow for better, more predictable regeneration of that socket. And so for this case, this is just a traditional, typical socket graft procedure that we're going to do every day in our clinic. So graft a socket. In this case, I used a non-resorbable dense PTFE membrane. And as I mentioned earlier, I'm not looking to get primary closure. I'm not looking to get primary closure because I want to ensure that I have good soft tissue maturation over the socket. And so if we have a socket with all the walls intact, all 4 bony walls intact, it's really not necessary to try to achieve primary closure. And if we try to achieve primary closure, what does that mean? That means I need to raise a flap. I need to hike that tissue all the way over. That's going to cover the graft and then let it heal for a number of months. And then what's going to happen? It means I have to go back later at the time of uncovery or implant placement and try and reposition that tissue back so that I have a wider, so I have more keratinized tissue. So by doing this way, we can ensure that we'll have a nice healed ridge that will have an abundant supply of keratinized tissue. So there's no need for primary closure when we're doing these socket grafting techniques. And you don't have to use a non-resorbable membrane. We can use a collagen plug, collagen membrane that will allow it to protect the graft. And after about 10 to 14 days, that initial healing with the epithelialization of the socket, you'll see some good maturation of that site. So this is 3 months later. Here's the radiograph of the healed socket. But this is what we're looking for. This is what we want to achieve, the picture on the right. You see that ridge there with that nice healed site where you have a wide band of keratinized tissue. And that's what we want to achieve with all of our cases. And so when we're doing these grafting cases, bone graft cases, we need to think of how is it that we can achieve good soft tissue outcomes when we're doing these hard tissue procedures at the same time. So for these types of sockets, we can be sure that by not having to graft, not having to advance the flaps to get primary closure, we can be sure that we'll have a nice healed ridge over that site. And looking at this, we can treat this now as either a flapless approach or raise a flap, ensuring that we have good keratinized tissue. And so for this case, I raised the flap because I wanted to see the bone, and we had good bony maturation. And then we went ahead and proceeded to do this as a 1-stage approach. Here's an implant with final restoration and crown restored. And so doing these simple sockets, this is very predictable. We can do this every day in our practices, with sockets. As long as we have good bony walls intact, graft the sockets 2/3 of the way up, or if you're going to use a non-resorbable, cover it up, secure the membranes with some sutures, let it heal for a number of weeks. And after about 2-3 months, you're going to see a nice, well-healed band of keratinized tissue over that socket. Let's go to this next case. This next case is a little bit more advanced, and I call this an advanced socket technique because it's a little bit more involved because this was more of an aesthetically challenging case. It was a younger female, and she presented with this. And if you look at this picture, this shows us a lot of deficiency, as we saw in the earlier pictures when we started the presentation, showing us how this biotype, how this phenotype is much thinner than what we would like to have in our cases. And so she presented with a tooth that was failing. She had presented with an abscess on the palatal, which was the cause of the infection. And as a result, we had treatment planned this case for long-term stability, meaning we wanted to have a most predictable treatment outcome for her. And being a younger patient, you know, we felt that for this case, that we're going to have to stage this case. We'll extract the tooth, we'll graft it, we'll come back later to place an implant in an ideal position, just because of the aesthetic demands. And if you saw from this picture here, what do you see on the lingual? You see these composite buttons because she was going through Invisalign treatment. And this tells you a lot about the psyche of this patient, meaning how aesthetically demanding this patient is. And if you look at this picture, looking at the buttons in the mandibular teeth, she wasn't really concerned about the buttons on the facial of those mandibular teeth. It's more the maxillary anterior teeth, the aesthetic zone, where, you know, she was concerned about the buttons being showing up on those teeth. So the other issue that she was having, she was going to be getting married within the year. So this was the case not for immediate implant placement, but to be more predictable and to be safe and to be less risk prone, we were going to stage this case with bone graft and then come back for implant placement. So here's the tooth removed, extracted, and you can see, now you can see the architecture of the hard tissue outline of how the soft tissue outline presents to us. And by looking at this concavity here, this really shows you just the amount of deficiency that's probably present underneath the soft tissue. And just by the thin biotype is telling us a lot. And when we have cases of thinner biotype, the studies are showing us that usually we have a much thinner bony alveolar bone present. So here's the socket. We made an incision designed to graft the buccal area as well. We wanted to treat not just the internal aspect of the socket, but because of that deficiency, we're going to graft the outer buccal plate as well. So we made an incision away from the midline and made only one incision to minimize any potential scarring, and then raise that flap. We're going to do our grafting, and you can see how after we raise the flap, looking at that buccal plate there. Now studies are showing that buccal plate on average, if you look at Hoing-Baugh studies, on average it's less than 1 millimeter thick, less than 1 millimeter. So that's not very thick at all, right? It's a couple sheets of paper. And just think about if we left that alone, what's going to happen? That's going to go away. We're going to lose that bone. So it's imperative in these types of cases, especially in the anterior aesthetic zone, we graft the sockets, but we also have to graft the facial plate as well. And so we're going to treat both the internal aspects and the external of the alveolar bone in this case as well. So for this case, what we had to do is, because of this deficiency of soft tissue, we wanted to try and maximize soft tissue support as well. So we're going to graft both, not just hard tissue, but we're going to do some soft tissue augmentation as well. So here's bone graft placed inside the socket. And then what I did was I initiated a pedicle flap from the palatal, because I want to bring this pedicle of connective tissue over so I can try and improve the biotype of this site. So here's the pedicle initiated. Remember, the pedicle, we're not detaching it from the flap. We want to keep it connected at the base. So here's my bone graft on the internal socket. Here's my pedicle. And then we're going to also go ahead, we're going to graft on the outer aspect of the facial plate there. And then we're going to lay a collagen membrane over the bone. And then we're going to lay the pedicle connective tissue layer over the collagen membrane and then suture everything. Now in this case, I wasn't looking to get complete primary closure, and I wasn't too concerned because I had this connective tissue pedicle that's going to be closing the wound there. So I did this so that we can try and improve upon the biotype for this case. And as you can see, we're able to reverse the architecture of the hard tissue profile that we first presented with, as you see in the picture on the right. So you see that little concavity there, we're able to over-engineer and build it out with both hard tissue and soft tissue, and then give us a more convex profile as you see on the left, right? So we want to address both, not just the hard tissue, but both hard tissue and soft tissue. And then temporization phase. For this patient, because of the aesthetic demands, we used a bonded mineral lip bridge to be able to provisionize, because she didn't want to use her aligners with an acrylic pontic, because every time she took the aligners out, she was saying then she would have a space there. And so because of the aesthetic demands, we just bonded a Maryland bridge into that site, and where the aligners were able to seat over the teeth. We worked that with the orthodontist. And so you can see here the healing after 1 week, soft tissue starting to mature. And then 4 weeks later, now look what's happening. look at what's happening here, right? And you can say to yourself, oh my gosh, right? What do you see here, right? Nice healing from the palatal. But that area there, even though we did all that hard tissue grafting, even though I did some soft tissue augmentation, I'm still getting a loss of soft tissue support there. I'm still getting this area of deficiency. And look at this. This is not even a full smile. What do we see? We see that triangle of death. We see that little black triangle. I apologize. This was reformatted. But that dark black triangle, that's all of us treating these highly demanding anterior aesthetic cases when we're dealing with that one implant. And so this is the healing. You can see how even spicules of bone still remained through the soft tissue, but you can see just how it's starting to shape and heal, right? So this is an occlusal view. And if you look at this occlusal view, we can actually appreciate, actually, it doesn't look too bad if we compare it to the contralateral side. It actually looks pretty symmetrical to the opposing side, right? So even though we over-engineered and overbuilt this hard tissue and soft tissue, we still got some rebound, we got some relapse. But looking at this case now, we can see we have some decent soft tissue where now we have the second opportunity to be able to treat the soft tissue aesthetic concerns for this case, which is why in this type of a case, it was imperative that we treat this as a delayed approach, meaning we stage the case, we extract it, we graft, right? Take care of the hard tissue support first, come back, and then now we can deal with the soft tissue concerns for this case. To make a long story short, this patient actually had to move. She was getting married and her family was in LA. And so she asked me, Dr. Kim, do you know anybody in LA that can kind of take over my case? And knowing the aesthetic demands of this patient, I said, oh, I know the perfect dentist. I have a few people I'll refer you to. So we are still Facebook friends. I see her. She's happily married. She had a baby. She's smiling in all the procedures. And I'm sorry, she's smiling in all the pictures. And I asked her to send me a recent photograph and along with a radiograph, an x-ray from her dentist, because I wanted to see just how the results came out. And I think the results have been pretty successful. If it wasn't, then she would have probably reached out to me by now. So, but this case was done about 4 or 5 years ago. And I'm pretty sure just understanding, by treating the bony foundation, treating the soft tissue foundation, we can come up with an ideal treatment plan, understanding the biologic principles, but knowing that we don't want to rush these types of cases and do these as a staged approach. And so when we look at GBR technique, there's different armamentarium, different tools that we can use that can help us for predictability and for success. There's titanium mesh, there's tenting screws. We can use titanium reinforced membranes, bone blocks. Neobiotech, they have this great GBR kit, very versatile. If we're looking to do vertical augmentation, horizontal augmentation, this kit itself has tenting screws in different lengths. It has fixation screws of different lengths. So whether we want to tack and secure membranes, this one kit really does it all. And it's very easy to use, very self-tapping, self-threading screws that makes it very, very easy. Where we don't really necessarily need to drill into bone, even cortical bone. And just showing you some step-by-step procedures. I'm not going to spend a lot of time in this, but they do have this kit. So I do want to get into this kit here, this case. This is a case I treated as he's a fellow dentist, actually. And so I had given a lecture regarding PRF and guided bone regeneration. And he called me up one day and he said, Dr. Kim, I'd like to come in for a consultation. I said, sure, you can come on in. And so he came in and I said, so where's your patient? And he said, it's actually me. I need you to do that procedure that you showed in your lecture on me. I was like, why? Well, he was missing some teeth in the anterior premaxilla, numbers 8, 9, 10. And he had bone grafting done already with another colleague. But he was a little deficient in terms of vertical augmentation. And so he wanted to see if we can gain some vertical augmentations so that he can have some implants placed in the future. And so we know who are the 2 worst patients that we can possibly treat in our practices, right? One is our family members, and second, fellow colleagues, right? Fellow dentists, right? So, and I was trying to sway him from trying to do the procedure. I said, these procedures, vertical augmentation is not very predictable. It's very challenging. May not always work the first time. We may have to do it again. But he's like, no, I want you to do it. I think we can get a good result. So I said, okay, if you're willing to take the risk and you understand the consequences, he's a fellow colleague. So I said, I'll do it. So this is how we presented. he had a provisional made from extending from number 7 to 11. He was missing teeth numbers 8, 9, and 10. And so this is how he presented. And you can see the augmentation was already done once, but he was a little deficient in terms of vertical height that he was looking for. And so this is the panoramic. And so the options were, we can use tenting screws, we can use mesh. Looking at the clinical view from the occlusal aspect, we have some decent keratinized tissue. So that's one positive effect for us for this case. And so he came with a wax up. He came with a diagnostic wax up, not just of the teeth, but a diagnostic wax up of the deficient alveolar ridge as well. And so here's a picture without the provisionals. Here's a picture without the deficient bone, the alveolar deficiency without the wax up. And you can see he was looking to gain some height in terms of alveolar bones so they'll be able to accommodate a complete implants to have some individual implants if possible. And so here's the full flap flexion, and we can see just the deficiency in height. He had decent width, but the height was what we were trying to gain. And we had some attachment loss on the adjacent teeth as well. And so for this case, we said, all right, we're going to use some titanium reinforced membrane, and I'm going to use all the PRF technology. But in order to gain some predictable vertical augmentation, if we look at Urban studies, he has some papers out in 2007, the sandwich technique, you have to use autogenous bone mixed with your allograft bone. And so there's this auto bone collector, ACM burr. It's like a trephine that's made by Neobiotech, and it has this little plastic sleeve that you insert over this burr. This plastic sleeve is already pre-measured so that as you're harvesting autogenous bone, it's not going to go beyond 4 millimeters in depth. So it makes it very safe in terms of harvesting some of this autogenous bone. So we're going to use this in slow speeds. We want to try and harvest as much autogenous bone so I can use that to mix with the allograft and xenographic bone for my graft complex. So here's the ACM, and you can see this is just one site, one core where I was able to harvest autogenous bone. And then I'm making my babe graft. We're not going to talk about that. I'm doing that at 5 o'clock for those interested. We'll be talking about sticky bone, PRF, and so forth. So I went ahead, we made this block putty complex, and then we're going to use that to try and augment not just more horizontal, but vertical, which was the main concern for this patient, for this case. And so we use this auto chip maker to harvest autogenous bone. Now, when we harvest autogenous bone, we have options of going to a second surgical site to harvest autogenous bone, as we do when we do ramus blocks or chin blocks. But with this machine, with this tool, what I do is I go to the site that I'm grafting to harvest autogenous bone. So if you can see from the picture here, here's a cord that I drew. Here's another cord where I was able to drill out, and a couple more cores here. Right, so rather than going to a second surgical site, I'm just going to core bone from the site where I'm looking to augment and use that bone. And because the way I look at it, what's the difference between having small decortication holes in the alveolar bone versus some large decortication? Essentially, this is a large decorticated area. And so I'm going to harvest autogenous bone, decorticate it to get some blood draw, to get some bleeding wrap phenomenon, and then augment the sites back anyway. So I don't have to go to a second surgical site. So I'm using the auto bone collector, auto chip maker to harvest autogenous bone. We're going to use this, we're going to mix it, and this is just a different case just showing how I can draw different cores of autogenous bone from one surgical site. And this is one draw, one core, and so I'm getting multiple cores to harvest autogenous bone. So I'll mix that with my allograft, I'll mix that with the liquefaction of the fibrin glue, and together as it mixes, it's going to form what I call this babe graft, biologically activated bone enhanced graft complex, also known as sticky bone, that a lot of you may be more familiar with. So I use this to harvest, to create this bone graft complex. And then for this member, I said I'm going to use a titanium reinforced membrane. So this is a non-resorbable titanium reinforced membrane. And using this GBR kit, I'm going to fixate it on the palatal, as you see here. We trimmed out the central area to accommodate where the incisive foramen is. I'm going to fixate it with 2 fixation screws. And then we're going to graft the whole area using this graft complex. So here's my my babe graft on the left. Here's my autogenous babe graft on the right. And then what I'm going to do is we're going to layer this. I'm going to layer this such that my autogenous bone is going to be laid down first, and then I'm going to lay down the graft complex over that. So I'm doing this, similar to the sandwich technique that Hamle Wang talks about. So now you see some more decortication areas within the alveolar housing, right? And then large decorticated areas up, much more up towards the vestibule. And I'm going to lay down, this is just autogenous bone right now. So you can see how much autogenous bone I'm able to harvest from those cores, from the autogenous bone collectors. So we lay that down, and you can see I'm already increasing the vertical dimension of that. And then I'm going to lay down the allographic and xenograft graft complex over that. And that also has some autogenous bone mixed within it. And then at the same time, I'm going to try and see if we can gain some attachment on the natural teeth as well. So we're going to graft just a whole area to try and regenerate as much as we can. So I'm going to over-engineer and overbuild. And then, again, critical to these types of procedures, we have to have graft immobilization. So that means you got to fixate these membranes so that there's no movement amongst the graft complex. So fixation, and then I'm using, again, PRF membrane. I'm going to place multiple layers over the graft complex. And then this is collagen membrane. So I'm going to use, again, remember, this is a colleague. So I'm kind of, just bringing everything to the table. I'm going to use PRF technology. I'm going to use collagen membranes, whatever I can that will give me the best predictable results. So I'm going to use these collagen membranes. We soak it in the exudate because this exudate still has growth factors, it has cytokines, right? So that's going to enable it to for better healing. And then, even in the literature today, there's an article in 2020 in JP that talks about using PRF and how it will actually be an advantage for biologics, for biologic materials, for membranes and bone grafting procedures. So here's the collagen membrane laid over the PRF. Then the challenging part of this is going to be getting primary closure. So I have some deep periosteal membrane tacking sutures that's going to hold the membrane in place. And then I'm looking to get primary closure of my flap. So that's going to be one of the more challenging things that we can do with this procedure. So I go in, deep incision to get release. And then I was able to get primary closure. And you're going to see here, you can see different suture materials that I'm using because I want to make sure and ensure that I don't get flap breakdown. I want to make sure that this flap stays closed. And so by having a deep release, making sure you get tension-free closure and using multiple suturing will ensure that I have adequate flap closure, and so that this does not break down, does not open in the near future. That's my biggest concern. And then using the provisional, reaming out the pontic areas so that there's no pressure onto the area. Here's 6 days post-op, right? Healing looks very uneventful. And so remember, I'm using vicryl sutures, I'm using PTFE sutures, and also we have polypropylene sutures, non-resorbable. Now I put this up because this is 18 hours after the procedure. So I did the procedure Friday afternoon. Sunday morning, I get an email. It says, "Thank you, doctor. God bless you. Less than 18 hours after surgery, very little swelling, no pain at all, but keeping with your prescription, and we'll get in touch with you later." And he had the liberty actually to take some photographs of himself of the area, and you see minimal swelling. I was just blown away just by just how well he was doing. And I do want to say I think it was part of just the technology with PRF and the growth factors for stimulating healing and so forth, and also with medication, proper pain control. We did put him on some steroids, Medrol dose pack, to account for the amount of swelling that was to be expected. Here's our CBCT. Here's our fixation screw. You can see here, right? This is all grafted bone. Right, we're looking at vertical and horizontal augmentation. Here's the outline of the titanium mesh. Again, outline of the titanium mesh. Here another depiction of showing you with the titanium reinforced membrane, fixation screws, bone. Another schematic showing, here's CBCT close-up view. And then he healed uneventfully. Here's 13 days, still left the sutures in. Still uneventful healing. Here's a palatal view. Look at the tissue though. The tissue quality looks amazing. And so for anything, at least the PRF, we know that the soft tissue benefits clearly is beneficial for our patients. So look at the soft tissue. This is 4 weeks now. Going at 4 weeks. Again, from the palatal view, soft tissue maturation, healing very nicely. Sutures removed at 4 weeks. I try to leave the sutures in for a minimum of 4 weeks with these large GBR cases. but also look at the healing around the pontic, look at the healing around the abutments. Very uneventful healing. Very nice healing for this patient, right? And plus, I mean, I'm sure he took good care of it. Here's suture removal, look at its occlusal view. I mean, this is just fantastic, just incredible healing for this patient, right? Lateral views of the canine, lateral views. This is 2 months post-op. Again, still no flap breakdown. My biggest concern was flap opening. Remember, we're using a non-resorbable membrane. So I was concerned that possibly the flap may break down. Here's a smile, right? You can see the staining. Here's 4 months post-op. 4 months and still no flap breakdown, still primary closure. And it's just incredible. I mean, this has just been such a great case to follow through. And then this is the before. And then he went ahead and, you know, being a clinician, he went ahead and he actually fabricated a new provisional for himself, as you can see at the above photograph. Now this is 6 months. Look at the healing. He went ahead and relined the provisionals. Now, beautiful temporaries he's made. I mean, you know, this is what we want to see. If we have a nice fabricated temporary, you can see the soft tissue maturation around the pontics, soft tissue maturation around the abutments, right? And so understanding the biology, understanding the healing, the benefits of having good soft tissue support, good hard tissue support. His smile line, very aesthetic smile. And then this is implant surgery. Now, I went back 8 months later to do implant surgery on this patient. This is 8 months post-op. Still everything nice and closed, nice and healed, right? This is with the provisionals off. Look at that soft tissue support there, right? Look at the keratinized tissue that we have. Look at the volume of tissue that we have. And so the question is, do we have bone underneath? There was no exposure, right? So now we go to uncover and expose the bone. I mean, this is the true telltale moment that we've been waiting for to see. Do we get regeneration? Do we get the amount of bone in terms of not just horizontal, but vertical, which is what we're looking to achieve? And so we removed the cytoplasmic membrane and look at what's underneath. This is just fantastic. This is just phenomenal, right? Nice wide bone there, nice wide band of bone. And then we went ahead and we did this as a guided case. So two fixtures with a surgical guide in place. And he's going to be undergoing ortho treatment as well. So that canine number 11 is going to be moved to the distal, and we're going to compensate that to make room to have a pontic there for a lateral incisor. But look at the volume, the amount of bone that we have. And so we had our fixtures in place, good primary stability. I'm going to go ahead. I'm actually going to graft a little bit more again. And then this, I'm using this is actually a amnion chorion membrane that I used over the root surface because I want to see if I can get a little bit more attachment on the tooth. Root as well, but I went ahead and we grafted a little bit more. I want to make sure that I have long-term stability. And in order to ensure that I have that long-term predictability and stability, we need to have good bone. And if we go to the studies, understanding how much bone we need to have on facial of these implants, especially in the anterior aesthetic zone, you want to have at least a minimum of 2 to 3 millimeters of bone on the facial. So here's more PRF and then closure. Here's 2 weeks post-op. I mean, the healing has just been phenomenal. And you can see the band of keratinized tissue where the mucogingival junction is way up here. So we planned, and I told them later when we're ready to do restorative, we'll go ahead and we'll do maybe a connective tissue graft to try and increase the vestibule a little bit and so forth. But this was a fantastic case to follow through in terms of management of not just the hard tissue, but seeing how the soft tissue can be managed because we have the hard tissue support for this type of case. And due to COVID, we weren't able to go ahead and begin the restorative, but understanding that once COVID passes in about 2-3 months, we'll be able to begin the restorative phase for this patient's case. And I know it's a lot to handle. I try to fit everything in within this hour, but understanding that, you know, it's not just about either just the soft tissue or the hard tissue, but having a support for both the hard and soft tissue and understanding how to achieve the results that we have so that we have the long-term stability and long-term predictability for these types of cases. And so I think I finished right on time at 3 o'clock, and we'll be happy to take some questions. And understanding that I know it's a lot that I went over, but here is my email, my contact, in case you do have any questions. And thank you for joining us. And I do hope that you all stay safe and healthy, and hope that we get over this soon. Thank you. Ayong, are you there?
Hi, yeah, thank you very much, Doctor. We do have a few questions here. Would you like to go over some of this?
Okay. Okay, does anybody have any questions? I'm trying to see if there's any. How
Yep.
long did I? So after that last case, I waited 8 months after grafting for the GBR technique. I think that's important that we don't rush these types of cases, especially with large GBR cases, and especially if you're trying to augment vertical. If you look at Urban studies, he waits 9 months, sometimes a year, before going back for implant placement. And so I think we do need to be a little bit more patient for those types of large augmentation procedures, and not rushing those types of cases. And the fact that he was a fellow colleague and he already had one round of grafting already, I wanted to make sure that we took some time to ensure that we had some predictability for that grafting procedure. Yeah, thank you. Did you get any other questions, Ayo?
Yeah, on the Q&A box.
I see. So as you get older, my vision. Okay, which bone graft material do I like to use? So I used a combination. I used a lot of the Puros mineralized cortical and cancellous. And I layered these types of larger cases. So as you saw in the last case, I try to incorporate as much autogenous bone as I can. So I will layer it in terms of autogenous bone first, and then I'll lay on top of that cancellous bone, and then on top, either the cortical or xenograft. So the further away from the bone I go, I want something that's not going to resorb as quickly. So that means I want to use something more like a xenograft away from the bone, or a dense cortical bone. But closest to where the alveolar bone is, the natural alveolar bone is autogenous and cancellous, and then from there, I kind of layer it as I move away. All right. And what's the best intraoral site for harvesting the autogenous bone? I try not to go to a second surgical site if I can avoid it. So usually for sites that I'm doing these larger cases, I go to those sites that I'm grafting right there. So I try not to open a second flap and harvest from a secondary site. I try to keep that surgery in one locale, meaning, the site that I'm looking to graft is where I'm going to try and harvest autogenous bone. So I go either deep, or I take multiple layers of cores, and then because I'm going to be grafting that area anyway, so I just try to stay confined to where I'm grafting for that procedure. Thank you for that question. Thanks for watching, Dr. Scores Yellow. When you augment the sites, you remove the autogenous core. Do you use a membrane? So I do use a membrane. When I augment sites, or I remove autogenous bone. So in the cases that I showed you, I'm using those sites, and I'm going to graft those cores with bone graft material. And then over that bone graft material, I'm using membranes. And so I'm using a lot of PRF membranes, but larger cases, I'm using PRF in conjunction with collagen membranes on top of it. So I use both. Yes, I do. Do I fill donor sites with allograft and use membranes over those too? Yeah, so the graft material, the graft complex I'm using, so I'm just placing more graft material into the donor sites as well. And so I'm just using that as part of that whole segment of graft area. So I will graft the donor sites as well. I know in certain areas, like in the ramus, posterior mandible, some studies have shown that you don't need to graft those areas, but I try to keep my grafting confined to the surgical area, so I will graft those areas and then use membranes. So would you use tenting screws if you had used a resorbable membrane instead of titanium reinforced? Yes, because of the titanium reinforced membrane within the non-resorbable membrane, I didn't need an additional tenting screw. But if I were using just, say, collagen membranes, then a tenting screw would definitely be needed, because you want to maintain that space and that volume, right? So with the tenting screw would need to be placed so that you can prevent collapse. The titanium reinforced has that durability, that structure that allows it to have stability and have immobilization and containing that graft so that we can have a good regeneration of that area. So if I didn't use titanium reinforced, yes, I would use tenting screws in those areas. Second part of the question is how do you decide on resorbable versus non-resorbable membranes? A lot of it is really clinician preference, what you're comfortable with, but also depending on what type of augmentation you're doing. If I'm doing vertical, I want something probably what I showed you with that last case, a titanium reinforced non-resorbable. If I were to do just a horizontal augmentation, I can probably get away with just using a collagen membrane. So I would use maybe some tenting screws, fixation screws, collagen membrane over that, and then get primary closure. But certainly horizontal augmentation is a little more easier in terms of procedure and predictability versus vertical. And I'll be first to tell you that I don't always get 100% vertical augmentation. I've had my failures. We just don't have the time to show you my failures. And, you know, those are challenging. And even with all the biologics and materials that we have, it's still one of the most challenging procedures that we do today with GBR. All right, thank you for that. Let's see. The case you did number 10, could you have placed implant palate and graft bone between implant and buccal alveolar bone? Yes, absolutely. If I'm understanding correctly, if you're talking about the gap distance, I place my implant and then the space between the implant and buccal alveolar bone, I always graft that gap. You know, if you look at Tarnow studies, you know, he talks about the gap distance. And if the gap distance is 2 millimeters or less, he says you don't need to graft. But I feel more comfortable grafting because if you don't graft, you're going to get some resorption. And if you look at the studies that talk about, you know, you run the studies, how much bone you need on the facial plate on the buccal of the implant, you need at least a minimum of 2 millimeters, if not more. So I strive to try and have at least 3 to 4 millimeters of alveolar bone, which is why you saw me graft that last case a second time when I placed my implant. I wanted more bone on the facial because I want this to last 10, 20, 25 years because we're going to get resorption. So in cases where, you know, in the anterior aesthetic zone especially, where that buccal bone is thin, you place your implant more towards the palate, the gap distance between the implant and alveolar bone, I'm going to graft those areas. And, you know, I have a different presentation where I show you how I graft the gap and then I lay a PRF membrane over it like a poncho to help with soft tissue maturation and soft tissue support. So I do that. So thank you for that question. There's another question. What would you do if the non-resorbable membrane exposed early? That's a great question. That's one of the biggest challenges is trying to keep that soft tissue closed. You know, one is surgical technique, ensuring that you have good primary release. The second is you have to ensure that I think the phenotype of the tissue that you're working with, the biotype, the thicker the biotype you have and the easier primary closure you can attain, the less risk of flap breakdown. I think if you have thinner tissue, if it's just more mucosa and you had good primary release, I think you're still at risk of flap breakdown and exposure of that membrane. So understanding, especially in cases, if you have large GBR cases you're working on, you want to have thicker keratinized tissue, right? Thicker phenotype, thicker biotype, good primary release, making sure you really go up and score the periosteum so you get primary release and then getting closure that way. If I did have exposure, how would I manage it? It depends on what stage of healing I'm at. If it's early on and within the, say, first couple weeks, I would go in and I would try to do a little bit more release to get primary closure, right? So if it's early on, I see exposure, you know, because the healing cascade has already started, right? Angiogenesis has been initiated. So I would go in, try and release that flap a little bit more and then try and resuture at that stage. If it was a little bit later on, maybe say a month or two in, then I may go in and still maybe do a little surgical procedure. And then maybe, depending if I can maintain the surgical wound, if the patient is able to clean, you may not necessarily need to do another surgical procedure. If they can keep it clean, say with Paradex and the tissue is healthy, then you can kind of baby it along. Same thing with titanium mesh. That's one reason why I got away from titanium mesh was the management. But if you look at those titanium mesh membrane cases, the exposure, it's very kind to the soft tissue. You don't see a lot of inflammation around the titanium mesh. So it's easy to maintain and very, not user-friendly, bio-friendly, if you want to say. I mean, it doesn't cause a lot of inflammation. So depending on the stage, will determine if I go back to try and re-suture the wound, or if I can maintain it with, say, Paradex and keep it clean that way. And then I may go in and try to expose and remove the membrane a little bit earlier, maybe 4 months if I can, right? So it's a hard question to really answer with exact protocol, but that's something that I would follow in terms of, if it's early on, I would try to go in and re-suture and close by getting good primary release. If it's a little bit later on, depending on what stage you are, then maybe trying to just manage and maintain it. Otherwise, go in and remove a little bit earlier, and then I can do a little bit more grafting, and then maybe just use a collagen membrane. All right. So I hope that answers your question.
Dr. Kim, thank you very much for answering all these questions. I think we are a little bit running out of time, so we still have your second webinar coming up. So maybe we could answer questions in your second webinar today. So I would just thank you very much, Dr. Kim, for your presentation. And is there anything else you would like to mention?
No, you just gotta, next time give me a little bit more time for the, there's so much to cover for these.
Yeah, definitely.
It's a good you, but my email, I gave everybody my email if they have questions or comments. And again, if they're interested, I'll be doing a second webinar later this afternoon. So thank you again, and hope everyone stays healthy and safe.
All right, then I will now make an important announcement in regard to upcoming webinars. Right, so if you're interested in taking our webinars, you can find upcoming webinars in our website at www.neobiotechusa.com, and just click webinar at the top, then you'll be on our webinar page. And we will have a second webinar with Dr. Kim, as he just mentioned, today at 2 p.m. Pacific Coast time, and on the topic of simplifying grafting procedures through the use of BABE, biologically activated bone enhancement graft complex. And I want to mention that all these courses are on first come, first served basis, so please register in advance and reserve your spot. And also starting on this week, on May, we will have 2 webinars every Mondays and Thursday. So total, we have 4 webinars weekly, and the date is like I just said, Mondays and Thursday, 1 in the morning from 11 to 2 Pacific Coast time, and 1 in the afternoon from 2 to 3 Pacific Coast time as well. And we also have another great lecture coming up on Monday, May 7th at 11 a.m. Pacific Coast time with Dr. Smiler on topic of implant dentistry. And also on the same day, on Monday at 2 p.m. Pacific Coast time with Dr. Spencer Park on implant stability. And here are also more added webinars you can find on our webpage. So the first one is Monday, May 11 with Dr. Lara on implant complication and failure. And on Thursday, May 14 with Dr. Jeffrey Platt on advanced bone grafting. And on Monday, May 18 with Dr. Ken Huang on basic dental implant part 1 and part 2. And on Thursday, May 21st. So please save these dates on your calendar, because all of these webinars are first come, first served basis. So please do register in advance. And so now you can watch previous webinars on our website, and just simply click the previous webinars on the top once you are on our website. And also please be advised that we do not provide CE for watching these recorded webinars, but these is all ready to watch for the archive. And I want to say thank you very much for those who stayed until the end. And as part of our ongoing effort to provide better continuing education courses, we would like to request your feedback via a short course evaluation. And one of our sales reps will email you the link to complete it. And this form should take no longer 5 minutes to complete. It's very simple. So once you receive it, please fill it out and submit it as soon as possible, because you will receive your CE upon completion of this form. And also please be advised that we receive a high volume of a number of emails and requests for CE. So please be understand that receiving your CE is longer than the usual, but we will take our best effort to respond in a timely manner. And thank you very much for participating in today's webinar, and we hope to see you again next time. Please feel free to contact me if you have any further questions. Here's my email, ayong.chuy@neobiotech.usa.com. And thank you so much for joining today's webinar, and we hope you have a great day and enjoy your rest of your day.